some of you are regulars to the Labor Academy, and some of you are from outside the Labor Party. So welcome to this discussion we're having on saving community health, which I hope is the beginning of a campaign. So my name is Janet McCalman, and I'm convener of Labor Academy Victoria, which is a grassroots political discussion group for members, for Labor members by members, and now affiliated with the Chifley Research Centre under Emma Dawson. Now, first, I want to pay our respects to the traditional owners of the lands from which we are all connecting online tonight, and that is from widely in Australia. And we acknowledge their continuous custodianship and that the land was never ceded. And at the moment in Victoria, we're proud that we've just signed the first treaty with First Peoples ever signed on this continent. But we should also acknowledge that the greatest success of community-controlled health in Australia has been the Aboriginal Health Services. They were there at the beginning with the Redfern Health Centre and continue to inspire the practice everywhere. And second, I want to pay tribute to the late Moss Cass, who was a leader in social medicine and one of the thinkers that was encouraging the whole idea of community health centres in the Whitlam government. But he was also the founder of Victorian Labor's unique system of policy committees. We're the only state branch that actually has them, and that's due to Moss. So the Labor Academy is part of that tradition of grassroots policy building. So we've got 3 speakers tonight. We'll open with Dr. Brian Stagoll, psychiatrist, teacher, historian, and champion of community health in inner Melbourne. The other major speaker will be Professor Fran Baum of Adelaide University, long recognised as the leading academic researcher and advocate for social medicine and better social care in this country. And Fran will be supported by her colleague, Denise Fry, who was the policy officer long ago, before it was scrapped, of the Community Health Association. So finally, may I ask you to put your questions and comments in the chat first so that we can curate them and that we can incorporate as many as possible. So thank you, and fire away, Brian.
This is a warm-up for Fran and her great document, Lessons Drawn from a History, which could also be titled Lessons Unlearned. I want to talk about community health, and I want to talk about social medicine. But let's first of all, the first point I want to make is that social medicine is a 200-year-old tradition. It's an underground tradition. It's an underground stream. The practical expression, the main practical expression of social medicine is community health. Now, this underground stream, it's a counter-current in the history of medicine. The dominant narrative, of course, is biomedical and technological medicine. But underneath, there's always been rippling this, beneath the waves, another voice that sometimes rises up to the surface, but then gets silenced again. So I want to strongly present that voice tonight, but I promise I won't go on too long because we'll leave room for Fran to talk about her great document. Now, so I'm going to talk about the vision, the history, the practice, and the community. First of all, the vision. That's the second slide. Oh, okay. Talk about being silenced. Okay. Silence is what happened to Fitzroy, Collingwood, and Kensington Community Health on October the 19th this year, when there was a very sudden, very surprising announcement that these 3 foundational centres of community health in the inner city were to be closed on December the 19th. They were to be closed by the Co-Health Board. Now, Co-Health came about when North Yarra Community Health, Western Region Community Health, and Doodagalla Community Health amalgamated 12 years ago on the basis we thought we would ensure our future by getting bigger. we were wrong. Although it worked for a while, eventually the Co-Health Board, and it's a very large organisation, far too large, lost all contact with the community, ceased all contact with the community, and became a corporate board. So I no longer call it Co-Health standing for community health, it's Co-Health Corporate Health. And they've lost all contact with their community. Nobody knows who's on their wretched board. And I fancied myself, I know many people in the health system, nobody else knows who they are. Our first reaction, let's go back to Adorno, the previous slide. We were stupefied, we were shocked and astonished. We were silent, we didn't know what to do. But we took heart from Adorno's line. Our task is not to be stupefied by the present, but to redeem the hopes of the past. And there you can see the great Adorno giving it the thumbs down. And this is what I hope to do tonight. Find our voice and redeem the hopes of the past. So let's move on to the vision of community health and the vision of social medicine. Let's just start with the Bible, of course. Where there is no vision, the people perish. Well, this is actually becoming true. Having lost the Co-Health Board, having lost the vision of community health, people will perish. People are going to die. They've tossed 12,000 patients overboard. Okay, the fight is on, and we can talk about that a bit later, but I wanted to go back to some fundamentals, and there are three great Labor figures. Well, two great Labor figures and one perhaps not. The first one, of course, is Nye Bevan, and his fundamental statement, the essence of a satisfactory health service is that the rich and poor are treated alike, that poverty is not a disability and wealth is not advantaged. This was followed up by another Blair health minister, Frank Dobson, who said, inequality in health is the worst inequality of all. There is no more serious inequality than knowing you will die sooner because you're badly off. To which I've added Moss Cass. Moss Cass is, I'll speak more about Moss, and I'm glad you mentioned him, Janet. Moss, among the many wise things he said, community-based services are the best way to deliver health services. Now for a cartoon. Brian can't resist cartoons. Have we got the cartoon? No. There it is, that one there. Well, it says there's a prosperous-looking patient talking to an even more prosperous-looking doctor who says, this is a very impressive resume, young man. I think you're going to make a fine patient. This is what Bevan called wealth being advantaged. And it seems to be the new policy of the Co-Health Board. Our patients have to have the right CVs. They can't have difficult CVs. If they have CVs that are too hard or too difficult, they're not fine patients, and we've got to get rid of them. Now, this absolutely goes against all the principles of co-health, of community health, not co-health. It's corporate health. So I wanted to go quickly through the history, and this is a vast subject. I'm just picking out a few highlights. The history. And our line here is, if we don't know your history, you can't know your future. I don't know who said that, but I'm very happy to actually attribute it to Janet, because that's one of the lessons I've learned from her over the years. If we don't know our history, we can't know our future. So our history. Let's talk about number one, Rudolf Virchow, typhus in Silesia, 1847-1848. Now, Rudolf Virchow, many of you will have heard of him, and David's written a fine article about him. This is the foundational story of social medicine. It takes place in the 19th century. Virchow, who is arguably the finest medical scientist of the 19th century, as a young man is sent by Bismarck to report on the typhus epidemic in Silesia. Silesia is part of Russia, up on the Polish border. It's the poorest, less privileged area of Prussia, and it has a terrible typhus epidemic. The conclusion that the great Virchow comes to is that the solution to this problem is, the remedy is full and unlimited democracy, the separation of church and state, rather than mere palliative efforts. Bismarck is absolutely furious. He challenges Virchow to a duel. Virchow ends up on the barricades with a gun in 1848. But I wanted to get to Virchow's fundamental statement. Can we switch to that slide?
Yeah.
Medicine.
Yep.
You've got it, Janet?
Yep, it's there.
There's another one. You sent me another one that's even more detailed. But his conclusions: medicine is a social science and politics is nothing else but medicine on a large scale. He also continues in that statement: physicians are the natural attorneys of the poor.
Yeah.
And I consider these the foundational statements of social medicine and community health. Now, if we can move to Australia, around about the same time, 1860s, we have the first dispensary in Australia. This, and you can see the picture of it there. The Collingwood, the free medical Collingwood Mission Dispensary, started by a Protestant evangelist, John Singleton, Dr. John Singleton, and he is modelling it on the late 18th and 19th and early 19th century models of the dispensary, which were an attempt to cope with the problems of the urban poor brought about by the Industrial Revolution. And it occurs, first of all, in places like Edinburgh and London, and then later in Boston and Philadelphia. And it's a service, now it's called a dispensary, but it is actually much more than a pharmacy, as the name would suggest. Medication and therapeutics are obviously part of it, but additionally clinical care, something called district visiting, minor surgery, something rather gruesome called casual dentistry, and vaccination, right? And these are the forerunners, if you like, of hospital outpatients, except they're based in communities and they do district visiting, which makes very clear the importance of how and where people live. So the home environment is regarded as central to the patient's condition. We heard that one before. And recovery isn't a matter of personal or moral decay. As one of the 19th century dispensary doctors said, no person can more readily appreciate the utter uselessness of drugs if there is no possibility of nourishing and warming the patient up. Now, John Singleton establishes his dispensary in 1866, and in 1889, he, by public subscription, builds this magnificent building. It's still in 169 Wellington Street, Collingwood, the dispensary. And this, I've got a picture of it, which is on the book that I had a large part in writing, Missionaries, Radicals and Feminists. And just to go through the title slightly, the missionaries are John Singleton and his mission. His mission was for the relief of the destitute, sick of every creed and clime. That's on the front of the building. The radical part is health workers in the 70s who take up the challenge of the Whitlam community health movement and build great community health centres that provide both quality clinical care and also are involved in a lot of social action. And there's many examples, but two of them that of great interest are their involvement in the anti-smoking campaigns and defacing cigarette company billboards. And the doctors at Collingwood were part of the hotbed of the Doctors' Reform Society. Now, the feminist bit's also interesting. John Singleton was a great supporter of the suffragettes. And he appointed the first women doctors in Australia. When the other hospitals and so on, Royal Melbourne Hospital wouldn't appoint the Stone sisters who'd come top of medical school, women shouldn't work in hospitals. He appointed the first doctors in Australia. They later on went to start the Queen Vic, but they started off in Collingwood at Singleton's. Similarly, Singleton's established the first women's refuges in Australia, as far as we can tell, with the quaint Victorian names of the Night Shelter for Women and the Home for Fallen and Friendless Women. Yeah, I love these Victorian titles. They're a bit out of date, but there we are. Later on, 100 years later, when the radical women's health movement got going in Johnson Street, Fitzroy, and that was blocked in every way by the medical profession and eventually collapsed, a number of the health workers there came to Collingwood Community Health Centre. So we also have a very strong women's health tradition. So that's radicals, missionaries, feminists. If anybody would like a copy, I'm very happy to provide one on PDF. Just send me an email. Let's move to the next slide. The next slide is the history since World War II. Now, this is a very elaborate history, and Janet rightfully asked me to shorten it, but I'll pick up a couple of points. That's a picture of Dr. Jack Geiger, who I actually met once. He was a young doctor who went south during the Civil Rights Movement and during the Freedom Summer and helped establish a community health centre in the Delta region, the poorest region of Mississippi. He went on to become a leader of community health in the United States. Community health now has 1,400 community health centres. We don't know about that much, except they're featured recently in the New England Journal that says they were about the only effective way the American health system could deal with COVID. Anyway, I put it in because I love Jack Geiger's quote. He was, of course, this was opposed every which way, and a Republican senator attacked him in the Senate and said, why are you providing food? How come that's part of healthcare? And Jack came back with the great line, well, Senator, the last time I looked at a medical text, the specific treatment for malnutrition was food. This is one of the clearest statements of social medicine I can find. Let's move to the next slide. The next slide is from Dr. Singleton to Collingwood Community Health Centre in Gough. And we're going to talk about Gough, Whitlam, Sydney, Saxon, Moss, Cass. I'm not going to spend a lot of time on Whitlam, and I'm sure Fran and Denise will take this up. But what the community health program represented was 700 different projects of all kinds: community health, rural health, workers' health, women's health, and most importantly, Aboriginal health. And established 25 community health centres in Victoria, all of which are going, although I would now say corporate health has disqualified themselves as a community health centre. Sydney Sachs came out with a book in 1973, The Little Green Book, and that was our manifesto for social medicine. And it was a whole new social direction. And I'm sure Fran and Denise will remember that and like to comment on it. Just interestingly, Sydney Sachs knew Jack Geiger. Jack Geiger knew a man called Sidney Kark, who'd established in the 40s community health centres in Zulu Natal. And Sydney Sachs had come from Sidney Kark's program. So we have an international social medicine diaspora coming up with Sydney Sachs and the Little Green Book. Thirdly, I just want to mention again Moss Cass and his landmark move with the Meat Workers Union in 1966 to form the trade union clinic, which later became Western Region, which is one of the reasons we amalgamated. Moss was still alive there and he gave us our endorsement. He would not endorse what they're doing now. I was inspired by Moss as a medical student. I remember when I went out there with David Legg, who's watching tonight. David, hello. we went out there, and I think Moss set our wayward path in medicine from meeting him. I continued to know him until he died. He is the great man of community health. Let's have the next slide. The next slide. There we are. That's the full version of Virchow, and you can get that off. I'm not going to read through it all. It's all there. I want to talk about the practice of community health, and this is basically cribbing from Fran's book, but just to make a few points, and I'll talk very quickly about it. First of all, just talk about the hospital versus community-centric views of care. Hospitals are places where you go, you mysteriously materialise and you dematerialise, and you're sent home to God knows what. And, you know, there's the full embrace of wonderful medical technologies. I'm not knocking hospitals. You know, we need them from time to time. But they tend to lose the plot when it comes to chronic and continuing conditions. As somebody says, medicine's a fascinating intellectual and technological discipline. The problem is that bloody patients bugger it up. And the answer to that is community health. Community health, because it's in the community, of the community, for the community, must come up with local solutions for local problems. You can't discharge somebody from your community. You've got to work out solutions. And community health is very inventive and innovative when it comes to solutions in all kinds of different ways and in different locations. Thirdly, I think that translates into what I call a social view of health. A social view of health means it's accessible, it's welcoming, it's multidisciplinary rather than hierarchical. There is access, including access through relatively low cost or free. It's open and it's not opaque. This results in what I call a social view of health, translated into a sociable view of health, and even, to use an old-fashioned Labor word, a socialist view of health. And I suppose we're not supposed to use those words anymore, but there we are. So I come up with the 4 Ps. It's public, it's population-based. You've got to work with the people who are in the community, not just the people who knock on the door or have the right CVs. It's participatory, and I'll talk about that again in a minute. And at its best, it's preventative or early interventive. That's the practice, and I'm sure Fran will take this up in more detail. So let's move to the last one, which is I want to talk about the community. The community is so important. The community is the beating heart of community health. The importance of community involvement, of representation and ownership. And we managed to do that over a number of years at North Yarra. We had very large meetings. Our AGMs were carnivals. We had 300 people. We had elections. We listened very carefully. I chaired a meeting every 6 weeks with 100, 150 people, 10 languages. What Fran has the nice phrase, building community solidarity. That's what community health is about. What I call, and that's the second, the democracy of voices and the centrality of strengthening networks and social connections. And this is one of the major tenets, I think, of social medicine. Building the importance of fortifying social cohesion and political voice, and recognising how much our social worlds impact on our health, both physical and mental. I'm very interested in that as a psychiatrist, particularly because every epidemiological stuff in psychiatry shows that about 30% of the variance of the incidence of any condition is connected with social isolation. Community health tackles that head on by building networks and strengthening, and it's an enormously powerful weapon. The third thing I've got here is just from John Singleton again, for every creed and clime. Nobody is rejected in community health. We take on everybody. We don't say they're too hard or too complicated or it takes too long for the doctors to see. That is absolutely against the principles of community health. The fourth thing, and I'll finish then, is the defence of our institutions. I want to show you a couple of slides, and we'll have the next one. This slide, which the T-shirt, I think the inventor of the T-shirt was Terry Jackson, was what we put on our annual. This is Fitzroy Community Health Centre around 1992, when we had an intense involvement with the community and a sense of the community, by the community, for the community, that they owned the centre, and we tried to translate that in every which way. That's what I talk about, the beating heart of community health. And yeah, it saved the community health in 1993 when Kennett tried to close it down. But more recently, get to the next slide, October the 24th. When the news went round our communities, what was happening to Collingwood, Fitzroy and Kensington, this is what happened at Fitzroy Town Hall. Over 600 people. We had to close the doors. There were 200 people waiting outside. This is what I mean by not being stupefied, by remembering our past, and by that way redeeming community health and redeeming our community health centres. And we are very, very active and exhausted dealing with a very tricky, perfidious, lying co-health board and middle management who's spreading all kinds of lies about what's going on. And to a degree, they've got the government's conned, but that's not going to happen, and we're going to win this fight. And Fran, it's over to you and Denise, and we'll work with any of your advice and wise counsel. Thank you.
Thanks. Thanks very much. Look, I have to give Denise's apologies. She actually had a fall a few weeks ago and she's really too tired to come on tonight, but that's fine. I wanted to invite her because she could have made such a great policy contribution, but she's very, very much supportive of the work that you're doing, Brian, and the perspective that you're showing. So I'm going to go to my presentation and I'll keep it as short as possible. But if people want to intervene or say anything, then please do so. I'd really welcome that. And what I really want to talk to is, to look at the history of community health and then draw the contemporary lessons at the end and some policy recommendations. And I'll try and do that in 15 minutes if I can. So I'll see how I go. But please, if you do want to say anything, just interrupt. That would be great. And I'm just like to acknowledge that I'm on the lands of the Kaurna people and pay respect to their elders. And I'd like to acknowledge their resilience through the processes of colonisation. I just wanted to start. It's funny, you quoted Nye Bevan too, Brian, but he, of course, said that a free health service is a triumphant example of the superiority of the principles of collective action and public initiative against the commercial principles of greed and profit.
Great quote.
And I think that's what we're kind of fighting for through the community health movement, of getting a health service that is public and is against the commercial principles of greed and profit. I'm drawing on a history that we were funded by an ARC grant. I won't go through who the researchers are. You can see them very quickly there, but you can see some Victorians, David Legg, Virginia Lewis, Jenny McMillan, who's online, and also Denise and a group of other people. And what we did was we used a lot of archival material. We reviewed over 200 community health policies from New South Wales, Victoria, South Australia, and federally. We had interviews with 93 people who had been involved. And of course, what we were looking at was the history of this community health program for Australia. And in that, it said that the whole point of it was that the provision up to date had been curative rather than preventive, as Brian has said, and rehabilitative, and noted that that imbalance needed urgent adjustment. So the quote I love from that report is: the community health services under particular consideration are those that are provided in the community where people love, work or play, which is a lovely quote, I think. And of course, Sid Sachs really drove that as the person who had chaired that commission. Now, the central points from that programme, I think Brian's already been over. It's about a recognition of social conditions, and it is that tradition of social medicine. It's an argument that community health care reduces the need for hospital care, that community health and welfare services should be coordinated, and the report noted the confusion in the services that were provided, the importance of multidisciplinary teams, and education and training in the community. And of course, community control, which I'll come on to. And I think it's important to note that, of course, the community health programme set alongside a lot of other supportive policies, Medibank, the Australian Assistance Plan, and free university education. So it was in a supportive environment. The thing we found in our study when we looked at the history, and this is what I think is really missing today, is this strong social movements underpinning the community health movement. And I'd love to hear some discussion about that and what people think about that. If we looked back to the 60s and 70s, there was a real spirit of collectivism that I fear that we have lost. The Aboriginal lands right movement that was linked to the Black Power movement, the feminist movement, the workers' health movement that was linked to trade unions, the Communist Party and the Labour Party, especially in your state, the LGBTQI movement, the international community health movement that Brian talked about, and also health professionals returning from working in low-income countries, especially PNG, was quite important in the community health movement. But there isn't now a strong, maybe in Victoria, you guys have got a community health movement, but I think generally in Australia, we haven't got that community health movement to lobby for these services. Factors that we found were important in our study to the development of community health were that supportive policy is crucial. In the 70s and 80s, there was much more supportive policy. As the 90s went on and we got divisions of general practice, we got neoliberal policies kicking in, there was a much less supportive environment. Social movements, the governance is vital, and the community governance is absolutely vital, not a corporate governance model. The range of service types is really important. The equity of access, the 3 A's of access: availability, they're available in a local community, they're affordable because they're free, and they're acceptable because they're culturally appropriate in all sorts of different ways. We had lots of stories, for instance, from Victorian centres where there was lots of interpreters, where migrants were made to feel really welcome, all those sorts of things. The multidisciplinary teams were very important. The kind of offsetting professional interests versus community interests. The AMA strongly opposed the community health because they were going to employ salaried GPs and they saw them as moving in on their patch. So that's really affected the development of community health. The focus, I think, on social determinants, advocacy and action across sectors locally is really important. There's been really uneven state development. And of course, it's really concerned with health equities. And I think very often we in a lot of our public policy, we've lost the focus on health equities. So just to quickly go through those, the supportive policies, this is just some examples. In South Australia, we actually had a social health strategy in 1988. Way before people talked about social determinants. There were women's health policies. There was a focus to have a ministerial review of community health in Victoria. The governance is really, really important. Here's just a quote from some work that we did, and this refers to the Central Australian Aboriginal Congress, which I really think sums up the value of community control. Our clients are actually our bosses. They think they're our bosses. They say, you're working for Congress and Congress is working for me. And that's the way they feed information into Cabinet, their governing body. Or the Cabinet themselves are part of the community and they're in a position to change it within. So a strong statement of the value of that. And in part of the history in Victoria, there was a paper called, this is New South Wales, the Community Health Advocate, when there was a fear that community health in New South Wales was going to be cut, there was a strong social movement really opposing that out on the streets. And a quote from Vera Boston, who headed up a community health centre in Victoria, just making the point about that, the interpreters and being able to translate that. There's a range of services from one-to-one groups, community development and social action and action with other sectors and advocacy. And there's just one example there of the kind of range of programs. And certainly in the latter days in South Australia, before our community health centres were cut, the ability to do that wider range of things gradually closed in as the kind of corporatisation and the neoliberalism just wanted people to concentrate on one-to-one services. So I think that's been a real strong policy direction that we found. I've already talked about that. I think groups have been a really important part of community health, not just working with people on a one-to-one basis. We've done some evaluation of that, and it's about skills and knowledge, access, support, and empowerment and solidarity. And an example there, just saying, if you hadn't been referred here for a play group, I wouldn't have even known this service existed. It was speech pathology, and my child would still not be talking properly. So just one example of how a group can hook people in. And then in terms of empowerment, you're not just saying to people you are the problem, you're saying that the structures are the problem and we have to work together to make them different too. So just a really different way of doing service delivery to just fee-for-service one-to-one. And then community development has been really important. That's just a quote from a nurse from country Australia, the Melbourne Women's Health Collective, where they also mentored women doctors, a lot of female medical students and women who are just interested in working and learning about women's health issues. So really doing much more than just providing the service. The Dell Street in South Australia, someone said a woman might come for a pap smear and leave with a lettuce because they had a community garden. So just expressing that kind of community feel. But we really documented this narrowing of service focus. And one of the people in South Australia said even community development became close to illegal. You couldn't get funding if anything had community development in its name. The multidisciplinary teams, I think they've been very well documented as being much more effective. But, you know, when community health started, that was a new thing. We kind of take that for granted now, but community health really pushed that barrel. And then a social view of health and centering the community. So this is a community development worker who worked for many, many years at Noarlunga Health Service in South Australia. And she said, I think that meant that ideas like community health, where you could put your resources into preventing illness, promoting good health, working with communities to change the social structure and to change the social determinants. And her work, she did lots and lots of things that actually did that. Another example, looking at outwork as a social problem. We've, of course, found lots of differences. They already had a network of community health services before the community health programme. And the state government embraced the community health programme, so it was very much institutionalised within the state government. In South Australia, we had a Health Commission Act, and the services were incorporated under that, and it gave them a real good degree of autonomy with boards of management that included local residents. And then in Victoria, there was no central regional planning in Victoria in the early 1970s, and they didn't want the community health funding, the then government. So instead, grassroots and bottom-up initiatives and very community-driven were able to access that money from community health, whether it was a trade union or a local community group or a church. So very, very big differences between the states. I think this person who worked in community health in South Australia summed up that I think the value of community health is that at its best, it addresses inequities. It means that you get to work with the most disadvantaged, most marginalised people in society. I think community health at its best was that part of the social system that brought dignity and honour to those people who are most marginalised. I think that's a nice summary of it. And of course, she says, I think at its best that was because we've lost that in South Australia. We also had a very active, as I'm sure in Victoria, a community health association, and our slogan was "Pigs do fly." And of course, I think that's still a very good slogan for community health, that it's still always on the back foot. I missed that one out. That's a bit about. So just to finish, I think our history of community health really identified problems with the Australian health system. And I think you've had a copy of these lessons to look at. But we obviously identified that the system's too hospital-centric. It's missing opportunities to prevent and intervene early in the development of illness. The coordination between components of the health system is still weak, especially between acute and primary care, but also within primary care. A shift to privatised services is being seen in Australia through an increase in fees and gap payments, and that's really reducing the accessibility of service. The corporatisation of health services, and a lot of people in our history mentioned that while the sector has survived in Victoria, it was being heavily corporatised, and they really regretted that. But generally, general practice is being corporatised anyway, and that's undermining the quality of health services and their capacity to implement the sort of principles we've talked about in community health.
May I ask, Fran, if there's been any response to the absence of institutions?
How do you mean the absence of institutions? Sorry.
So what were you just talking about a split second before? Sorry, excuse me.
Oh, in terms of in South Australia.
Yeah, is there so there was something there, or there isn't something there?
There isn't. We had a network of community health that was very strong in the 80s through the 90s. It was gradually eroded. First of all, a whole lot of inappropriate performance measures. Then the boards were dissolved, and then they were told they could only do chronic disease management, and now that's all they do. There was a campaign to try and keep them, but once the boards had gone, the advocacy voice for the centres, once they were abolished, there really wasn't that strong voice, and the services had lost their links with the community. So we sadly lost it, and actually Mark Butler, at the launch of our kind of history, he kind of said, well, look, I know community health's the model, but we've kind of it's too late almost. I think that was his feeling. It wasn't that we had to make the policy argument to him. And in South Australia, and there was this argument that primary health care is what the government does because it funds general practice, and the state should just do hospitals, and that really was taken on board in South Australia. So we've completely lost our community health centres.
Well, thank you for answering my question. And a seed, if properly cultivated and cared for, becomes a tree. So thank you.
Yeah, that's great. Anyway, once. The other problems we've identified is that fee-for-service medicine is fragmented, increasingly corporatised and costly, that the system is opaque and difficult to navigate, that increased specialisation is fragmenting services even more, so there's more need for complex coordination. Citizens and health service users do not have a strong voice in the system. And we really like to differentiate between users and citizens, because I think that they have different interests. So I could talk more about that, but I won't now, but I can if we want to. For-profit services are not effective in providing for services for and improving the health for those most in need. And health professionals still do not get good multidisciplinary team education, despite all the years of saying that it should. And they don't get training in services which emphasise prevention and promotion. And those functions are rarely sufficiently funded or valued in an acute care funded health system. So that's the 11 points that we found were the problems. And then we made a series of policy recommendations. We think we need a national policy statement on community health, and the Labor government should do that. Denise Fry is really strong on this point from her experience, that we need a dedicated community health unit in the federal department, because I think, you know, from her experience as a policy officer with the Community Health Association, unless there's someone in there who's kind of batting for community health federally, you're not going to get the funding flowing to the states. So I think that's a really important point. Collaboration between the federal government and the states and territories was important in establishing the community health program. So we still need that kind of collaboration, some sort of joint work on it. We need recognition that it works best when there's strong community and consumer influence on how the organisation is run and managed, rather than corporatised or government-run models, and Brian's really made the case for that. Services should be free or low cost at the point of use. Support for ARCHO should obviously be continued and strengthened. And interestingly, the community health programme didn't fund the ARCHOs. They were there alongside, they were established before, but the community health programme, according to Denise, never actually funded them. We need to fund fit for purpose community health research and evaluation. One of the reasons they abolished the centres in South Australia was saying, oh, there's no evidence, but the sort of evidence they wanted is just a misunderstanding of what evidence you can produce. There needs to be an expansion and strengthening of multidisciplinary education, and a national community health advocacy body should be funded again, like the Australian Community Health Association. So that was our main policy recommendations for how we think we could strengthen community health again. And I mean, our overall conclusion was that it's a fantastic model, and you know, we'd be mad as a nation not to go back to those principles and pursue that as the basis of our health system. So there we go.
There we are.
So thank you to Fran and to Brian. You're going to start thinking about your questions, and there are a lot of people on the call who've got things to say and experience to impart. Could I ask people in the audience, first of all, who've got some experience, to give examples of where, in fact, community health saves a lot of public money? Now, when we had the public meeting at Fitzroy Town Hall, one of our local members, who's a doctor who was very prominent in the campaigns during COVID, he is an emergency clinic doctor in a hospital, and the figure he quoted was that for every dollar spent in community health, that saves $14 in the hospital system of when cases get to that point that they end up in the hospital. And so in these times where anybody thinks of money as the measure of everything, which is something we can thank for the 1990s, John Howard and so on, the argument can also be that if we want to really improve health and save money, that community health is the way to go. The other issue is that our medical students are graduating with debts in the region of $200,000. There are people in the Labor Party who still say, oh no, our scheme of HECS was brilliant, it was a wonderful idea. No longer, it's a bad idea now. And this is meaning they can't buy into a practice, they can't become general practitioners unless they get a job in a community health centre, and there they only get paid piece rates. I think there's only one doctor on a salary in the system in Victoria. And so the other option is to go and work for some foreign-owned corporate system where they have to whiz through their patients every 6 minutes. Terrible way to practice medicine, and very unsatisfactory. So we're wasting our medical talent, and far too many of the graduates see their only pathway to being able to have a viable income is to become a specialist. And we've got too many specialists in many areas. So we've got to do something for medical graduates as well. We're losing a valuable workforce. So I was wondering if there's anyone who's going to volunteer some commentary, first of all, on what both Brian and Fran have so eloquently presented. Have I got any takers? Come on, Peter. Well, I'm just wondering, one of the things that maybe we could start talking about, I'll ask Brian, because he was reminiscing about things that they did which had brilliant effects and were terribly cheap, such as meals in cafes.
The cafe meals is a very interesting program. We had wonderful young nutritionists, and they had the idea we have a large group of homeless people because they're eligible for Meals on Wheels. That's when councils used to provide Meals on Wheels. That's another problem. But so the problem is, where do the Meals on Wheels deliver if people are homeless? And they had the idea that they would develop a cafe meals program. And the idea of that was you got a membership ticket, and they'd negotiated deals with several of the cafes around town, the cheap ones, and said, if people present this ticket and pay a minimal fee, we'll cover the rest of their meal through our Meals on Wheels grants. Now, Vera was very involved in this, as I was, and it was taken up by about 200 people. They were very interesting, and it was a very nice program. One of the interesting effects was it was the homeless group, people were seeking to become a member of this club. And then they would go to cafes themselves as groups and have dinner together. So the problem of social isolation and disconnection was reduced. And our nutritionists would meet with groups of them and talk about nutritional solutions when you're in boarding houses and stuff like that. And it was do you want to comment on that program, Vera? Vera, your microphone's muted.
Oh, you're muted, Vera.
Okay. Yeah, I think I've got it now. Can you hear me?
Yes, you're fine.
No?
Remember cafe meal?
Good. Okay. Yeah. Well, of course I remember it, Brian. Yes, and I think one of the major benefits was it kind of normalized the whole experience.
Yes.
When you're receiving Meals on Wheels, it feels a bit like a charity thing. When you're just going to a cafe and you're ordering a meal and you're choosing what meal you want, and of course there's a price limit. We would only cover it up to whatever it was, $10 or $15 back in those days. But all the participants kind of reported feeling a great sense of empowerment. I think the best quote was someone saying, I no longer feel like I'm on the outside of society looking in. I'm actually a part of society looking out. So, just being able to go into a cafe and order a meal had a fabulous impact on the recipients. And there were mainly people who lived in rooming houses. And of course, it was very difficult for the Meals on Wheels drivers to deliver to rooming houses, and there often weren't any facilities for heating meals or even eating meals. So it was a very innovative and effective solution.
I called it the Melbourne Club for the Homeless.
It continues. It continues today. It's one of the few programs that continues.
Yeah.
Yes, Kay, could you unmute? You need to unmute, Kay. There we go.
Yeah.
With us.
My name is Kay Beeson, and I had the wonderful privilege of being employed by Western Region Health Centre in 1986 when work care came into Victoria.
Yes.
And I had to be the instrumental one of setting up all the rehab services, and it was the most delightful thing. There were 10 full-time doctors on at Western Region Health Centre, and I was privileged enough to be in one of their consulting rooms. And this was the way it really worked, because injured workers, it was the most fabulous thing for the whole family to know that Western Region Health Centre had every service for their needs.
Orange and cinnamon or green? Not green, peppermint.
Pardon? Sorry?
I think someone's ordering their cup of tea.
Oh, no, but it was just wonderful. And because because I'd had a fair bit of setting up billing services, even though I'm a social worker and a health scientist, I had this way of getting that. I did the submission that went into work care. It was accepted. It was the first government money producing venture that ever went into a community health centre. But we got ourselves out of terrific debt by this wonderful work care, where you would have a 3-monthly plan for recovery, and that would all be approved by the government, how many services we needed. And it was just absolutely gorgeous, because we could go right through from the minute they came in with their injury to when they were totally back to work. And we had an orthopedic surgeon who worked there, and we had a general physician. And does anyone remember these days at all with Western Region?
They were glory days and they're now gone.
Yeah, I know. But I'm just bringing it up.
Hello, Mum.
Huh? What happened was when the government started leaving it open slather for any physio, any chiropractor, anyone that had some kind of reasonable health piece of paper, could just, that they knocked us all out of the water, because we couldn't compete when it became open slather. And also I was instrumental in working with the old Broadmeadows, which became, what was it called? Broadmeadows set up a service like we did.
Yeah.
And it was just the way to go. It was really the way to go.
Thank you, Kay. That's terrific. Now, Peter Fitzgerald has his hand up.
If I can, it could be tangential, but I'll make the contribution anyway. I'm involved in activism to try to do a couple of things. One is the next slab of HECS forgiveness, for advocating for a national jobs guarantee, but also to dovetail with a set of other things on the go, like having a national emergency response framework. In all of these three things, the care economy presents itself. So when we say, I spoke to Monique Ryan, of all people, a couple of weeks ago. I said, look, thank you for the petition for getting HECS forgiveness. If we wanted to get something in response to the next slab of forgiveness, what comes to mind for you in terms of what the community would get? And she said something in the care economy. You know, send students out to the service deserts, get them to do some work in exchange for HECS forgiveness. Call that an idea. Likewise, national jobs guarantee. When I spoke to Jim Chalmers, he said, look, great idea. Think about the care economy. How can you dovetail that with the care economy? You do the third bit, which is the national disaster response. God, if only we had community health centres who could coordinate, disaster response. We do have them, but they're not tasked with it. So I think there needs to be a next generation movement that says grassroots jobs, care, soaking up unemployed, the underemployed, the blokes with old bad backs. Where could you give them jobs? In the care economy, apparently. What could you do with them? Well, you could do, I don't know, community health. Can you help out with the vaccinations? Can you help out with the maternity health? So I think we've got to reinvent stuff that was around in the 70s. And can I say what a privilege it was to be, an acquaintance of Moss Cass. We've got to catch some of that zeitgeist from the 70s that said we've got 101 initiatives of a community nature that need frameworks and funding and political support for it. That's my little speech. Thank you.
Thank you, Peter, and that's absolutely critical. And I hope that out of this meeting, a little bit might come about how within Labor we do organisation and activism. I mean, one of the important things that's happened to the Labor Party in the last 10 years has been the growth of what I call horizontal organising, which has been extraordinarily effective. So Rainbow Labor would probably be the first, and then LEAN, the Labour Environment Action Network. We've been talking about doing one on mental health, because we have the problem in Victoria that the Royal Commission has not been implemented. But do we actually need a one which is all about health, in which mental health is part, and of which community health centres have a very important role? So something I tried to advocate for quite a long time ago was for community health centres or someone to start offering jobs to, in my community in North Melbourne, to Africans, particularly to men who had the language skills, to be health brokers between their community and the health system, because mentally ill African men and all other migrant men encounter white middle-class women as the health system, and it doesn't work. I was wondering, Brian, have you got thoughts on that? Because I think it's part of your experience too.
Oh, yes, but yes, I have lots of thoughts, but I've sort of spoken enough, Jan. I really want to hear from everyone else.
All right, okay. But so the other thing which was really critical, and Fran may have something on this too now, is the way that community health centres helped with COVID. Now, the really outstanding performance in that area was the Aboriginal Health Service, which was absolutely spectacular in the way that it protected the most vulnerable group in the country from cross-infection. But I know that in Victoria, in Collingwood, they had the money they got from the Commonwealth, they didn't spend on professionals, they spent it on what they called community health concierges, who were therefore able to go into the communities and explain about vaccination, explain about keeping safe, and try and deal with the terrible trauma and stress that happened in our towers when they were locked down and completely quarantined, which was handled as well as you can in a crisis like that. I'm not in any way criticising the way it was done. It is always going to be traumatic, no matter what you do. And people thought maybe they should have sent social workers in instead of police. So, you know, and I know it was about 9 o'clock at night. I live close to these towers, and Richard Wynne, the minister responsible for it all, lives opposite me, and I saw him in the street, and they had to get the police in because other people, the Greens, wanted they should have been able to rustle up at that time of night in a total lockdown of the city, 200 underemployed social workers who would hop into their cars and would drive to North Melbourne. Wasn't going to happen. The only people who are trained to deal with an emergency are the police, and there was no alternative. And the virus was going mad in a community which is highly social in those towers, and there had been cases have been spreading at a terrifying rate. But what the good part of it all was these health concierges that the health centres had the money to employ. And that's something that we've got to increase, and particularly important for mental health. And if it being the first port of call that people who are in distress might begin to trust the system. They're not going to cure anything, but they're going to listen. They're going to be there, and they might provide some trust. So any thoughts on that?
Yeah, I mean, I think that's really good. And I think, you know, the idea of having the community health centres as a centre of disaster response, whether it's a virus or it's an environmental response, makes a lot of sense. we're dealing with this terrible algal bloom in South Australia at the moment, and there's nothing in the community that can really respond. You know, if we had our community health centres, they would be, because there's a lot of mental health distress that people seeing dead fish on the beach and, you know, not being able to walk on the beach and getting all these respiratory symptoms. But, you know, the other thing we thought about is that, you know, if you step back and think what we've done with the NDIS and aged care, childcare, we've privatised. You know, we've privatised it. Imagine if you said, we're going to have these community health centres in a community. They'll be providing aged care, disability support, mental health support, a lot of overlap between those groups, have a beautiful community cafe. You know, you'd have groups meeting, you'd do all the things Brian's talked about. I mean, it would just really reimagine how we'd see health, you know, but of course, you know, the problem is that this idea that the market is much more effective than government services. But I think, you know, we'd have to put work into how you get the community management to work, because community management isn't always ideal. And I think the Archos have put a lot of work into that over the years of getting their community management models working. And I always felt in South Australia, the Commission should have done much more training for people. And I don't know if David Legg would like to talk about the role of the district health councils and how they, you know, how you could have those, well, how you could have a sort of population health council that works alongside very local community health centres to give not just a clinical perspective on things, but a population health perspective. And I don't know, Stephen Duckett's smiling away, thinking she's being too idealistic. I can see that with his hat on. I might ask Stephen to come in and tell me how I'm being far too idealistic.
I'm just waiting for David to give us a short presentation on the district health councils.
The district health councils was an attempt to create a focus on a regional population which, without the service delivery functions of the community health service, it was never completely implemented in Victoria, and it was a victim of the debt crisis of the 1980s, which gave us the State Bank collapse in South Australia, the Pyramid Building Society collapse in Geelong, the debt crisis in the Third World, and the Kennett and destruction of publicly delivered healthcare and publicly delivered services. But it also gave us, with the so-called Washington consensus, it gave us the idea that somehow the market delivers everything. And just picking up the point that Fran made about the amazingly efficient and productive aged care system we now have delivered through the market, the amazingly productive and efficient early childhood care delivered through the market, and that one of the boiling frog moments in community health was when the community health centres said we must get bigger in order to compete in this new marketplace for commodified service delivery, and we will compete with the private providers. And the getting big and the getting corporate were part of the same boiling frog. The earlier boiling frog, of course, was the defeat of a national health service, which was Moss Cass's vision, which was overridden by Gough Whitlam and Bill Hayden, with the turn to a health insurance model which supports a private medical system. So from that particular point onwards, community health was always going to be residualist in certain respects. So we've got residualism and we've got marketisation. Is it any wonder that we've got the disaster that Brian has described?
Well, Stephen, I think the ball is in your court.
So I'm more, well, as Fran is suggesting, I'm more of a pragmatist than a optimist. I mean, I think we've got to say we are at point A now. How do we get closer to the principles of the community health movement as we saw it back then? And what are the key elements of that? Now, my own view is that there has been some work done on what I would call a coalition of the willing. That is to think about establishing some form of mechanism for integrated, multidisciplinary, team-provided community health services. And one of the ways that could occur is through cashing out of Medicare benefits. That is, rather than have a service which is billing Medicare for everything it does, you say this service serves this population, and so we will pay it as if it were billing Medicare, but we won't require you to do item 23s and so on. The issue with that, and one of the complexities of it, is how do you ensure productivity and how do you ensure the right type of service provision? I think one of the problems with Medicare at the moment is that it does not encourage multidisciplinary care. And so you end up with parallel systems of medical provision and allied health provision as separate corporate entities rather than integrated entities, as was the vision of the community health services. So that's something that I think we have to think about, how we advance that. What I've described there is a clinical program that does not involve any of the elements of community engagement that Brian talked about. And I think that is an issue as well. So I think it is, as I said, getting from here to there is complex, but I think we've got to think through what is the appropriate path to get there from here. And I think it is possible to think that through, but it is quite complex. And yeah, I'll just stop there.
Fran, have you got a comment?
Yeah. Well, Stephen, I mean, you pose the problem of how do we get productivity, but it seems to me at the moment we've got a medical specialist sector that's really price gouging. I mean, I don't know if you'd agree on that, and taking lots of money out of our health system with and increasing the, you know, like some of the data we looked at, the North Shore of Sydney uses far more specialist services than the Northern Territory, for instance.
Yeah, I think that's all true, Fran.
But I mean, what you've got is a really, you know, the classic unequal distribution of services, and as Janet's pointed out, you've got medical students wanting to go into specialties because they can make a shed load of money and pay off their debt. That's one of the reasons they want to do that. And working for a salary in a community health centre probably isn't very attractive to them. So, you know, it seems to me a lot of the problem in the health sector is it's about demand, but it's also about supply. And there's an increasing literature, you know, on health, on the provision of a whole lot of imaging that isn't necessary, a whole lot of futile care. So, you know, I think if we're taking a whole system perspective and we want to look at productivity, we have to look at all those supply issues that are quite perverse within our health system.
Could I throw in some demography, please? We've got an ageing population. We baby boomers are probably the healthiest generation in history. We grew up with fresh food, we played around outside, we all had our vaccinations, we had a lot of exercise, we didn't eat a lot of sweets, we didn't live on sweet drinks, and we're going to live an awful long time as a cohort. So, you know, we're all going to hit the late 90s. Now, the cost to the health system, as we know, will be absolutely crippling, with a diminishing taxpayer base to pay for it. Is this where we think through and appeal to the public and to the politicians that here's a way of doing things far more economically, and that it just simply providing services so that some people can make a lot of money out of them is a very inefficient, because the people who end up paying most of the money are actually the users or the clients. So the price gouging that's going on with specialists is particularly happening with the added fees they're putting on, so that you might get $100 back to see your oncologist, but he's taking $500 out of you for that one visit. So it's the narrative we've got to start with the public, and this is where a political party has a role in how we talk to people, is helping them to think through the very long term. Because I remember someone telling me that the thing about medicine is innovation never reduces costs. It only increases them, because you've got new machines and new procedures and you need new staff. And so we're not going to see efficiencies come from technology and developments. We're going to, you know, they're one of the few ones has been cataract operations, but not many things work that way. So how do we get the conversation going in the country that we're going to have to think very carefully, because otherwise our health system is going to really fall over. I think it's very close to toppling now. Our hospitals are having great trouble in Victoria keeping within their budgets. And there's just, we don't have the money in the country available to the public purse to produce the sort of society we want. So that was a conversation killer. But I mean, I think demography drives a huge amount. And so what's happening to the population, particularly if the Conservatives get their way and cut immigration, then we're in very deep trouble, because we simply won't have the taxpayers, let alone the workforce who are so important in health care and the care economy, to be doing the work on the ground. So what's ahead of us is actually quite grim, and that we can't expect to be in the comfort that we are now. And there's going to be many more of us. The trouble with being a baby boomer, as many of you will remember, is that there are always too many of us. There were too many of us to get wanting jobs when we graduated. There were too many of us wanting to get into university. The generation was just a bit older, had it lucky, because they were a small demographic cohort. They got all the good things. By the time it got to us, and I knew it was going to happen, we'll end up with shortage of spaces in the crematorium. So there's a problem with a population boom. It has these echoing effects that go on forever. So do we start a narrative around a new vision, which is reviving the community health, reviving the multidisciplinary work? And for the young doctors, I think many of them would very much like a decent salary and not have to pay their insurance. Now, that's one of the big incentives to get doctors to work in the system for a salary, because the burden of paying insurance, particularly if they'd like to do some obstetrics, is actually quite prohibitive. So in talking when I've been teaching medical students social health, not a bit and over the years, and they are receptive to that sort of a career. even at the University of Melbourne. And that's saying something. So I'm sure other medical schools are a lot more progressive than Melbourne is. But I think there's an opportunity. And
Just a comment.
I
think iPhone has his or her hand up, by the way.
I'm sorry?
iPhone has his or her hand up.
Oh, sorry. Yeah. Hello, iPhone. Come on.
Hello. My name's Mary Beth. I've had to change iPhones because I ran out of battery on my other, so I've had to borrow. And one of the things I just wanted to say is that we seem to be very fixed on the medical model, and when community health is talked about and discussed, and Fran Baum, who I'm also a big fan of, talked about community health being a multidisciplinary team, and that doesn't always involve a centralist medical practitioner involved. But the other thing that, just to cast a different light on things, and that is that NDIS hasn't been mentioned at all. It's been it's been available to people, a great large population of people that have never been considered at the centre of planning before, and it's been incredibly, for all the naysayers and it's costing money, it's been transformative and an example for Australia at an international level as well. So I think that there are limits to everything, and I think that that's only reasonable. But I also think where the community health sector is concerned, I think there's a plethora of people who are probably not being, resourced and tapped into, that are really doing some marvellous work. I'm from Sunbury, and the Sunbury Community Health Centre is split at the seams trying to service the community, and it is a community that's in that middle range between metropolitan and country. So it's got a very broad population in terms of health requirements and health needs and community needs and social needs. But then the other thing that I also wanted to mention was that our population is expanding. It's expanding internally and for those arriving in our country. And that's a good thing, of course. But when things like housing, somebody needs to save for 10 years consistently, not get sick, keep their job, study, and whatever that means, before they can actually put a roof over their head, it is something that I think is fundamental in terms of any kind of move forward. So I think that there's really good things like the emergency services clinics that have been initiated at federal government level, as well as the women's health clinics that have been initiated. In my sector, it's regionally in Kyneton, regional centre associated with the hospital, and has the range of services available to it. Just another kind of tweak to the community health centre model. But yeah, there are things happening, and I think hanging on to the medical model really isn't going to work for us very well into the future. So thanks.
Can I comment? I agree with all of that. I mean, and I think the social model of health, as I presented it, is in fact the alternative to the medical model. But I wanted to also just not be too stupefied. I wanted to go back to Fran's document. That's an excellent document, and it contains a number of very sensible and possible recommendations, and we need to really support the recommendations that are in that document. That's one of the ways to go. Before we get too catastrophic, let's celebrate and let's do what we can do with what we've got, which, as our previous speaker said, is a hell of a lot. There's a lot of really good workers out there who really get it. And how do we join them up? How do we celebrate them? And how do we move forward in a coherent way at the next level of policy?
Thanks, Brian.
Anne here, could I say something?
Yes, please, Anne.
I think we're in a very good situation with our federal Minister for Health. can't do everything, but we have someone who buys the idea of integrated care. We don't have to sell it. That's completely different, in my mind, to the situation in the States, where they're busy doing the Solomon. The baby is yours, not mine. So funding shifts are the big thing, and ideas get, sort of lost. I think this now, with the review of co-health, is only one part of the health, community health network that we want to preserve or increase or modify or transition, whatever the word is. We want the model to live into the future. This is an opportunity. Up until now, we've had projects, loads of projects. The best care is the right care, the best treatment can prevent hospital admissions, we can delay joint replacements, we've had projects, but no substantial ongoing funding commitment. That's what we need. We need to take the risk and have a funding model. It might work, it might have to change. What did they do with NDIS? They took a risk. Time to take a risk with this. And I think the review, we've got until the middle of next year. We've got documents and recommendations and stuff. We should move on that. And I like the idea of, Stephen's idea, how do you know productivity? Well, give it to the patients. Let them tell you. So I worked all my life in HIV medicine. How did that come to work so well in Australia? Because the patients had so much influence. They said, hey, this is a load of codswallop. We don't want that. We want, home care. We don't want to be hospitalised. We want, teams of people coming out to help us. All the other research things, rah, rah, rah. So I think somewhere in the model where the community gets a say in whether the KPIs are right, whether the stuff in the black box is doing what the community needs. That's how you ensure that it works. People don't want, unnecessary crap. They want real care, prevention, their kids, food, all those things, the basic needs of life. And I think this is an opportunity. It's been a disaster, slightly averted, thanks, and an opportunity now. We shouldn't lose it.
Thank you, Anna. I think
Janet, could I have a word?
Yeah,
Yes.
please.
Yes, just in response to the last comment by Anne, unfortunately, as I understand it, the review that's been announced is really just going to focus on the medical practice. According to Co-Health, they've already sent out notices to all their staff saying that the pharmacy will close on the 19th of December, that the Collingwood building, which, as Brian indicated, was the direct descendant of the Singleton Clinic, is going to be sold in the middle of next year, and that all the counsellors at all those 3 sites are going to be terminated on the 19th of December, a week before Christmas, and that in all likelihood, the medical practice after this review will still most likely be closed down. So in a way, Co-Health has preempted the outcome of the review. Like Anne, I thought that the review was going to be looking at the whole of Co-Health, what went wrong, how did this organisation of which North Yarra Community Health, that I was the CEO of, was a willing participant and was in a good financial situation. How did that happen? How is it possible that management has allowed two deficits in 2 years, a $7 million deficit in 1 year and a $6.5 million deficit in the following year? How has that been allowed to happen? What is intended with the money that they will get for the sale of Collingwood? Is that money going to go to support services in Tasmania, in the Western region, is somewhere else that's deemed to be more profitable? The city of Yarra has got the highest number of housing high-rises and housing commission apartments in the whole of Victoria. Most of those residents, the Richmond residents go to North Richmond, but the Fitzroy residents go to the Fitzroy Community Health Centre. The Collingwood residents go to the Collingwood Community Health Centre. Where will those people go? Where will they go for pharmacy? Private pharmacies charge $5 a week to fill a dosette. How are those people going to find that money?
Yep. Yep.
That's my little brave, because I'm pretty disappointed with what's happened, and I can't find it in my heart to say that the federal government is doing the right thing, because to my mind, if they're allowing this to happen, that's not the right thing.
I think that there has to be a very big questions asked of co-health, and we are seeing.
And who will ask them?
Something rather like the Baum disaster, that we've got corporate cultures spending money on things they shouldn't, and incompetence and greed. And do they have the right to sell the buildings, which they will get an extraordinary amount of money?
They own the building. They own the building.
Well, do they?
Well, who is going to stop them? If the federal government isn't going to stop them, who will stop them? How will this be stopped? Not by sitting around saying it's a terrible thing.
We might have to think of some direct action.
Can we be lawyers actually looking at what the deal is in terms of stopping them, like what can be done under the Health Services Act? I don't know, Stephen's probably on top of it, but certainly, is it possible for instance, to bring in administrators, or for them to be overridden at all, which I presume would have to be at state level, not Commonwealth level. But I'm not sure who's actually, where is the central point at which activism is happening around just stopping the things Vera's just been referring to happening, or for instance, lobbying the Commonwealth in relation to broadening the terms of reference of the review.
Yep. Thank you, Jenny. Valuable. Fran, do you want to have a last word?
Well, yeah, from my point of view, looking across the border from South Australia, where we've lost the community health sector, I think it's really worth a big fight to try and keep what you've got. And I think what Jenny's just said would be good, to get those terms of the review widened. That seems essential, because from what Vera's said, if you don't, you're kind of condemning the service anyway to be residual. But that's, if anyone's got Mark Butler's ear, to talk to him about that and say, look, you're risking losing a comprehensive service, and he gets that language, coming down to be a much more sort of selective service on primary health care. But I think, and it could be the thin end of the wedge. That's what happened in South Australia. It was cuts by, first of all, they brought in performance management, then they diluted the boards, then they did away with the boards, and it was a cut, sort of 1,000 cuts death, and then eventually we didn't have any community health centres. So I think fighting at this stage is what you kind of need to do.
Well, can I just comment? We are fighting.
But I know you are, but for
one of the things you can all do is get out there and fight on our behalf. Just tell everyone what's happening.
Oh, yeah.
Local members, tell everyone you can. That would be helpful.
Yeah.
We are fighting.
Yeah.
And like hell we're fighting, but yes.
Is there a sort of manifesto of demands that we could use?
Yes, there's all of that.
Yeah, but is it like a one-pager that would be really helpful? Because if you've got a one-pager, I'm happy to send it. Mark Butler's my local MP, actually. So.
Wow. Sorry, can you give us a call? We'll.
Yeah.
Sorry, who's speaking? Is that Jenny?
Yeah,
no,
Jenny.
it's Fran, Brian. But if you do have some sort of manifesto, I've certainly not heard about it, and I don't know whether other people on this, to say nothing of the people that aren't on this, have seen it. So where is it, and how can we get it out and about?
And it should have the specific demands like broaden the terms of reference, stop the sale of the buildings, retain the pharmacy service, strengthen community health across Victoria or whatever, but I also think I do think we need an Office of Community Health federally, so that the federal department is actually thinking about community health, which it doesn't at the moment. And the only person who did, there was a really good guy. What was his name, Jenny? Simon. You remember?
Oh yes, Simon.
Anyway, he retired.
Cottrell.
Simon Cottrell. He got it. I think he understood what we were on about, but he's gone, and I don't know that there's anyone in that federal bureaucracy who really understands community health now. And
I think Mark's not bad. I don't think.
Okay, it's not bad, but I think Simon was a particularly strong advocate.
We've got to keep getting to Mark. So any of you have connections with Mark, get onto him, please.
But a one-pager would be really helpful, to send around, I think.
Oh, sure.
Could I just add that in a few months, if nothing happens, there's going to be an absolute collapse of medical services in this area. There are 12,000 patients who are now about to be deprived of their GPs. None of the practices of which I'm familiar have got the room to absorb them. They're high needs. Whether it's Kensington, where overwhelmingly they're African from the high-rise flats, or Collingwood public housing, there is no way the local practices can absorb them, so they'll be hitting the hospitals. So one thing to do, perhaps, is to get the hospitals and the local GP clinics to all put their voices together and say, we can't cope with this. You're sending us a tsunami of high needs patients whose rights have been thwarted and which we simply can't have room on our books.
Can I also suggest that Jed Carney, who's the Assistant Health Minister, be another port of call, who is located in Victoria, and
she's
also
in an adjacent. She's in the adjacent electorate. She's in Cooper.
Yep. She also trained in Victoria as a nurse and was involved with the Australian Nursing Federation at a federal level.
Yep.
And that, I think you will get a very good sounding board there for a lot of what you've been talking about.
Yes, that's a very good suggestion.
Sorry,
wonder how people can.
Sorry, Jed is no longer. Sorry, Brian. Jed is no longer the Assistant Health Minister, and she has been briefed kind of informally by a person who used to work in community health and is actually now the Mayor of Darebin, so she has been briefed about it.
We're contacting all these people. I just wonder, Janet, can you send out an email? Or you can use my email where people can contact me, and we will send stuff on.
Yeah,
we are doing all these things.
Yeah,
and we do have statement of demand. Yeah. We just need to get it out more, and I agree with that.
Yeah.
Could I just suggest, Liz Barton here, that you get it through the branches? I've already introduced it to the Cranbourne branch and spoken about it because I'm very concerned about it.
I've spoken at 3 branches, and I'm happy to speak at any branch that I'm invited to.
I believe I could be a help of giving the speech maybe some cultural sharpness if anyone needs anything like that. But I'm still just a nomad for this point.
Yep, great.
Well, if I can get all your email addresses, that will be a help.
Anyone who doesn't want their email address shared with Brian, put their hand up, please.
Okay, there we are.
Right.
So Jeff Barber's also here. He's co-chair of our campaign.
Yeah. So I'll send that list on to you, Brian.
Thank you.
Okay.
And everybody get out there and spread the word.
Yep.
And
Thank
and
you
I
very
also want to go back to what point I made. Fran's document has a number of very sensible recommendations, and we must endorse that in the strongest way possible.
Well, it's on the Labour Academy website, and we'll have a edited film from this. We can also make little films that some of the vignettes of what people were saying were very powerful, so we can take those out. If you want to use those in your campaign, you can. This is all talking to a younger generation. We don't do these things, but you can send them off on Instagrams, you can send them off on Reels and Facebook, Twitter, all that sort of stuff. But it's the way you get through to younger people. And for younger people, the message is that they'll get, they believe in rounded care, they believe in multidisciplinary care, they don't like professionals ripping them off, they haven't got any money, they feel very depressed about the future, they are a very important support group. So look, thank you, it's late, thank you all very much, and particularly thank you to Fran, who's put in a lot of work and who's recovering from shoulder surgery. Are you all right now?
Well, nearly getting there. Lots of physio.
Oh, good.
And I can afford healthcare, I think.
Yeah. And Brian.
Got a good CV.
Yeah.
So I just want to thank you all and thank the audience and thank all the people who spoke. There's actually a tremendous collection of experience on this call, and that's ideal for doing policy thinking. I mean, we're not going to come out with refined policies. It's the job of someone like Fran to do that. But what we can do as Labor Party members is advocate, and that's our job. So thank you all, and may we look better forward to a more collectivist and socialist future, if I dare say, where we